We will now move to the next session, Potpourri of Cardiac Imaging Beyond the Echo. The presenter for this session is Dr. Johann Christopher, and the expert for this session is Dr. Y. Chandrasekhar. May I invite Dr. Christopher and Dr. Chandrasekhar to the dais.
Good afternoon, everybody. It's a post-lunch session, and I think we really enjoyed Dr. Chandrasekhar's exposition. One of the important things that I was really happy to hear from him is the need for investment into knowledge base in terms of imaging technology. While we're very good at what we do as cardiologists, but I think we need to look around us, invest our time and training, if not us, our junior colleagues, into imaging. As you can see how beautifully he showed you, the future of especially structural heart disease weighs a lot on the appropriate utilization and understanding of technology and other imaging things. So I'll just spend the next half an hour briefly going through some cases where we have used imaging over and above what we conventionally use. Some of these may be off-label, but just to give you an idea of how to explore the utilization of these techniques. Once again, thanking the West Bengal EZECHO chapter for giving me this opportunity, and it's been a pleasure to come here year on end to share with you our experiences. So imaging, as you've seen, there are a lot of options in front of us. It's very important as cardiologists and physicians to be able to use these in a very cost-effective and in a good resourceful manner, so that we are able to utilize the new technologies with a specific focus to help our patients. Now, if you just look at gatekeeping, you will realize that if you have a patient with a significant LV dysfunction, whatever the cause, the techniques that are available today, for example, dobutamine, PET, SPECT, and CMR, and in the position paper for heart failure, in which we have given a recommendation, we have mentioned that if you have a diastolic wall thickness of less than 5.5, it is appropriate and useful if you utilize a PET and MR compared to the other standard techniques. And only if adequately viable would you go to the cath lab and get intervened. If, however, you have a minor event, mild LV dysfunction, then it is important to have a stress either using echo, SPECT, or dobutamine MRI. And then if the patient has significant ischemia, then go ahead to the cath lab. This is also going to come out in the ischemia trial, which is a forerunner to the COURAGE trial. And we have seen in our ischemia patients that both the groups, these are high-risk patients, chronic stable angina with positive stress scans, also doing well on medication. In those patients who don't have a prior event, then CT angio, as you see the NICE guidelines recently published, is coming in a big way to screen our populations. Very easy to do, safe, the radiation doses are getting better, and also its utilization in other patients, especially structural heart disease, which Dr. Chandrasekhar really showed you. So there's a huge application of CT especially. I'm not going to go into all the details, but these are all the areas in which we've been able to interpose CT especially to help our patients, whether it's in the EP lab, whether it's in patients with congenital heart disease, so on and so forth. So I'll just start with the case. It's a 57-year-old lady presenting with worsening shortness of breath, atypical chest pain. She's had an anterior MI, not thrombolized, and PCI was done in another center, and about 4 weeks later she came with signs of heart failure. So as is typically the case, this angio was done, and you can see that the right coronary and the left circumflex are normal, and there is an osteoproximal total occlusion of the LAD stent. Now, what do we do next? So there are a lot of options for us to do, whether you just go ahead and do a PCI to the same vessel, or do you want to look at ischemia versus viability in this patient using MRI? You want to help the operator by using an invasive IVUS to check what is there in the stent. Is it just thrombus? Is it neointermittent proliferation? Or would you like to use CTA in this patient? Is viability important? We just saw that a couple of lectures ago, and if you just look at meta-analysis, you will see that clearly there is a definite role in revascularizing viable patients, and you can see the death rate really just drops there compared to those patients who are on medical therapy. However, when you do revascularize patients with non-viable myocardium, no major benefit with an increased mortality in the immediate short-term period. So for various reasons, we just went ahead and did a CT in this patient, confirmed all the findings, but what we also did see was that the entire stent has a diffuse kind of narrowing. The dark areas are the new intermental proliferation here, and what is more important is that there is no track of the LAD beyond the stent. The entire vessel is thrombosed, and we're using this technology especially in CTOs now. I'll just come back to that later. What we also did was using our dual energy perfusion scan on the CT, using exactly the same procedure. We got very nice dual energy images of the LAD showing a significant thinning and scar here. The dark areas are hyperperfused myocardium, and the normal orange areas are normal perfusion, showing that the entire LAD territory was thinned out and scarred, showing no viability. This is on CT. The initial work has been done by Lardo et al. In 2006, and we have come a fair long way from there, although not really replacing MRI, but CT now has a clear role in outlining viability, and you don't need to do anything extra, just the normal CT technique. However, if you want to delineate the scar well, you need to wait for about 6 minutes later and then just rescan the patient without fresh contrast. And you get a scar delineation which is almost akin to what you get in MRI with a very good spatial resolution. So you're getting perfusion, you're getting viability, and you're also getting the coronary, and also most important, you're getting the track of the vessel beyond the osteoproximal stenosis, which is very important for the interventionist and the surgeon. If he's going to graft the vessel and he's not able to see it, then it's going to be a major problem in the theater. So in this case, the management in view of no track of the LAD and also significant thinning and non-viable myocardium would be optimal medical therapy, and review this patient after about 40 days or so, and if the patient continues to have a severe LV dysfunction, plan an ICD as per the guidelines. Second patient is a 54-year-old male, atypical chest pain, he's diabetic, he went on a pilgrimage, complained of some pain, was admitted, the TROP-T was borderline, no other features of heart failure, came to us, the angiogram was done, and you can see here again a proximal total occlusion of the RCA. The left side was normal. So again, we have data and we have done some work on the role of CTA in CTOs, and there are a couple of papers which have now come out. In this particular patient, when we reconstructed the vessel after CT, you can see that we have a very nice distal vessel, and we have certain features here that are favorable for crossing, and I will just go through that. And this has now become an established tool, which is part of the computerized tomography registry of chronic total occlusion, or the CT Rector score, where you look at certain parameters like multiple occlusions, stump being blunt, severe calcification extending to more than 50% of the vessel, bending more than 45 degrees, second attempt at PCI, and a duration of CTO more than 12, gives you a number of points here, and then based on the points, you know the easy or difficulty of the procedure. In this case, our patient had a 0 score, and the PCI was done very comfortably. This is the basic overview of how we manage our CTOs, and I'll just go through that quickly. First is the identification of the CTO. As you can see here, there's a patient with a circ occlusion. We did the CT, and then you can see here the entire track is outlined. So you identify the CTO. You look at the clinical benefit by looking at the perfusion on the same CT scan. This is the picture I took from the last patient. And if you have significantly viable myocardium with adequate thickness, normal perfusion, you would go ahead. The third thing is to look at the procedural outcome. And then we have a couple of parameters that I already talked to you about in the CT Rector score. In addition, you look at the length, generally more than 15 mm. And if there is something called negative remodeling, these things adversely affect the chance of performing a successful CTO. The fourth thing that we look at is the pre-procedural planning, and then during that we are able to actually see what is the composition of the plaque, presence of calcium, presence of non-calcified material, tortuosity, and we are able to then measure the length and also the diameter of the vessel. And then the final thing is to fuse these CT images onto your cath lab image, and then that serves as a roadmap for a successful CTO. And then when you want to follow up this patient 6 months to 1 year, then again CT has a pretty good role, and you can see very pristine images of the stent, especially if the stent is more than 3 mm in the proximal vessels, then the visualization is quite good with the kind of iterative software that we have. Most of the blooming artifacts can now be done away with. So that was the role of CT in a chronic total occlusion. Now the third case is a 67-year-old lady. She's hypertensive diabetic. She has angina, class 1 to 2 since the last 2 months. She has bilateral osteoarthritis, both knees. She has been put on optimal medical management. The angina has come down, unwilling for any invasive approach. However, with persuasion, the referral cardiologist did an angio. These are still images. You can see the circ lesion here and a long segment LAD lesion. And you can see that the right has a total occlusion with retrograde flow from the left. So a triple vessel disease. So what would you like to do in this lady? And I just gave you a little snapshot of the fact that she is elderly. She's not wanting any intervention. So how do we go from there? So bypass, she was not ready for it. Do you want to just do PCI to the LAD LCX and just leave the RCA, or keep her on optimal medical therapy? So here we interpose a stress maybe to assess ischemia if possible in a culprit vessel. And since she has bilateral osteoarthritis, she's not going to do a good stress. So we use adenosine, and you can see that despite the apprehension most of my referral cardiologists have, adenosine has a very good correlation with quantitative angiography and intravascular ultrasound measurements, and serves as a very good tool for us in these kind of patients, especially when they're going in for non-cardiac surgery with a fair good amount of sensitivity. And if you look at the images here, you can see that there is a significant perfusion defect here, both in the stress, in the right coronary, in the circ, and also here in the LAD territory. So all three vessels, and this is very nicely brought out in the polar plot, where you have ischemia in the circ, ischemia in the right coronary, and in the LAD in the apex. And there is significant improvement on rest, showing that not only the area is viable, but there is significant ischemia in multiple coronary territory. And if you look at long-term data that is available, you will clearly see that a positive maybe scan or a thallium, for example, has a very good discriminative value to tell us the probability of cardiac events compared to just a plain treadmill or an angiogram for that matter. And having a normal, near normal stress scan in the presence of triple vessel disease gives you good protection compared to a high morbidity mortality if the scan is positive. And this is the score again that we use here, that we not only look at the severity of defects, but we also look at the extent. So if you have a triple vessel disease and a very severe perfusion defect, by the color coding, we have 10 colors that we use. So the darkest color with multiple vessel gives a very, very high event rate, and helps us in the prognosis. So if you have somebody with more than 10% defect and a LV dysfunction like this patient had on stress, these are the patients who are not going to do well. They have a poor event-free survival, and that helps us convince this elderly lady to undergo a triple vessel arterial bypass with a good result. The fourth patient is another 58-year-old lady, presented with chest pain since 1 month. She's hypertensive diabetic. No significant changes on the ECG except for LVH. Echo did not show LV dysfunction, no regional wall. Angio was done because she had chest pain, and these are the angio images, again sent from a referral cardiologist. And this is a right coronary. He had difficulty in cannulating this patient. There was some damping in the right coronary, and he had also severe difficulty engaging the left, significant ventricularization, so he was just giving bursts of contrast. You can see the various views. It was very difficult to really appreciate, but because of the hemodynamic disturbance, and a few attempts later he had to come out, and not very sure, but there was a lot of haziness, left main possible involvement, and so we were not sure what to do, so he referred this patient. Generally in patients like this, we do a maybe stress scan, either using adenosine, which is a little safer, but in view of the left main involvement, we thought that doing any kind of stress would be dangerous, and she was already symptomatic. So we thought we would look at the anatomical confirmation of the lesion. Now we have a whole plethora of techniques available to us, but in this particular patient, we did not want to use any invasive technique because he was just not even able to put the catheter in. There was significant hemodynamic disturbance. So we decided to use CT as a tool to look at the stenosis of the left main, plaque morphology, and also if there was any scar. And these are the CT images. She was an obese lady, so the pictures are not great, but you can see that the right coronary is fairly normal, no problem there in the ostium. And this is what we saw when we looked at the left main, severe calcification obstruction right from the ostia of the left main extending into the LAD, and different views again, showing you the significant obstruction of the left main right from the ostia. That's the reason why the catheter was not able to even just sort of go in, resulting in significant hemodynamic disturbance. And also we found that the circ was also quite important, the proximal circ, this is diagonal. The circ here you can see also had a significant lesion which was not very clear on the angiogram. So with this anatomy and patient being symptomatic, we opted for doing a bypass using Lehmann RA grafts to the LAD and OM1. So now multiple papers now coming out with the role of CT in patients with borderline or ambiguous left main disease on angiogram. In a good number of these patients, CT has been able to adequately risk stratify and outline the left main in these patients, being almost equally accurate, maybe better, and obviously much more safer in these patients. And the beauty about CT is it's three-dimensional, so we can take measurements all across. It's very easy to take cross-sectional measurements, view it in all angles, and then be clear about the thing. These are two cases that wanted to illustrate how the ostial left main looks important here on the cath, and and here again on CT it is a tight lesion, so both corroborating. Whereas in this patient, again the left main looks involved, but when we do the CT, it's a real open-ended left main with absolutely no atherosclerotic plaque as well. Also, this is a tool which is good if, in case the left main is important, you want to do stenting. We've had these sessions in NIC recently at Hyderabad, and a lot of work being done on left main stenting. So characterization of the plaque of the left main is going to be very, very vital in planning your hardware and your strategies for left main stenting adequately and using the right kind of balloons and stent sizing. The next case is a 71-year-old lady. Again, having angina on exertion, she's hypertensive on medication, non-invasive tests other than showing LVH had nothing. The angiogram was performed. She was symptomatic. There's a right coronary injection. You can see that there is a mild plaque in the distal RCA. And this is the PD injection. And the operator tried, I think, multiple times with various catheters for about an hour, but he was just not able to engage. And when he did, there was just a small trickle of flow in one of the vessels. The procedure was abandoned, and then this patient was sent to me. And we opted for doing CT because we know the role of CT in anomalous coronary vessels is almost a 1A or 1B indication. And here you can clearly see here, this is the pulmonary artery, this is the aorta, this is the right coronary artery from the right sinus, and you can see that the left main is coming off the right sinus here, between the aorta and the pulmonary artery. You would believe that this is malignant. I'll just come to that a little later. And then when the pulmonary is cut off and you have the VRT images, you can clearly see that the left main was coming off the right coronary sinus with some mild narrowing and then dividing. These are the VRT pictures. And this is the bird's eye view of how it actually looks. And you can see the right coronary has a borderline lesion here in the mid segment, but nothing else. And you can see that the left main coming from the right coronary dividing into the circ and the OM1. And this is the LAD with some mild plaque dividing into the diagonal. So no major stenotic lesions in the native vessels. And there was some mild narrowing of the left main and coming off the right coronary sinus. So options in this patient on the face of it, this looks like a malignant course, interarterial course, and we generally know that when the left coronary comes off the right coronary sinus, it's generally malignant. So we have some options here. We chose to do a stress maybe in this patient, and we used adenosine because of her age and inability to walk. One of the things we have, in fact, we have published about 12 of our patients. These are patients who have anomalous origins, mainly of the right coming off the left. We have found that 60% of them, despite the anomalous origin, actually have negative MIBs. And I'll just come back to this picture to give you an idea of what we're looking at. You will see closely here that apart from the interarterial course of the vessels, what we are also seeing is the relative height of the origin of the anomalous vessel. So in this case, the origin is fairly low. It actually passes along the fibrous cusp of the valve and has almost an intraseptal course, compared to if this particular vessel had a higher up course and was actually coming between the muscular portion of the two vessels. And in our series of 12, it's a small number, we found that if the origin is lower down, it seems to have a sparing effect on the vessel. And the MIBs are actually negative. And these patients now have almost a 1 to 2 year follow-up, which we have just published, just on beta blocker, despite the so-called malignant course. So we went ahead and used an adenosine in this patient. This patient had multiple opinions from a couple of cardiologists, and various options were given. We did an adenosine in this patient with adequate hemodynamic parameters. And you can clearly see here, it's a beautiful normal scan here. In the polar map, again, stress and rest, absolutely negative for ischemia. Patient was put on optimal medical therapy and was nearly free of angina a month later, and no surgery was planned for her. So just to show you the utilization of one or more imaging tools in daily practice, how it sort of helps us in risk stratification and also the treatment of these patients. I still have a couple of minutes. So there's another 48-year-old lady, chest pain, diagnosed to have an interposterior MI from outside. She was thrombolized in a smaller hospital, referred to us for a rescue angioplasty because of persistent chest pain, ST elevations persisting. We did the echo like we normally do on these patients when they come in, and we found a significant pericardial effusion, no tamponade. That was worrisome to us. And again, we have a series of about 10 patients. So we went ahead and we were thinking of, is there a possible myocardial rupture in this patient? So do we do a T? Do we do an MR to see the rupture site? Do we just ignore it and just do an angiogram and see if there is any ventriculogram, and then see if there's any leakage into the pericardium? So we ruled out all these three for various reasons, being either invasive or semi-invasive, and we went ahead and did a CT on this patient. So this is what the CT looked like. So the CT confirmed the presence of pericardial effusion. You can see around. It's a good study. Even at a heart rate of about 90, 100, we have a dual source Siemens scanner. So no issues with heart rate. And you could see the contrast extravasating into the myocardium here. And this is a composite view showing the contrast in the LV going into the myocardium. There is areas of low Hounsfield units around with some amount of, you can see that the perfusion is decreased at this area. And then we had a good look at the coronaries, and you can see that this is the culprit. The OM has got occluded here and is thrombosed, and that's caused the MI, and possibly because of the adjacent hyperkinetic segments, there's been a tear in the myocardium, which you can see here. So with this diagnosis, we just quickly shifted her to the theater without having to do a angiogram. And what we did was, we just did a pericardial patch repair because that area was already infarcted, not a very big vessel, it was completely occluded. So no time required for just putting a graft. We just did a pericardial patch. All the other coronaries, as you've seen, were normal. And this patient made a very quick and early recovery. So this is one of the journals in which we published our work. We have now 10 patients actually who we did CT in this kind of a setting, failed thrombolysis, not thrombolized, persistent chest pain, coming with pericardial effusion, possibility of rupture being there. So before we take to the cath lab, give heparin, we're doing CT. In 10 of these patients, 8 of them survived. 2 of them, these were early cases where the cardiologist didn't believe that this technology was there, and the patient died overnight. The second patient, the cardiothoracic surgeon didn't take the patient because he was not very happy about the delineation of the rupture. Patient again died overnight. And so we think that this is an interesting technology, especially in this difficult subgroup where the echo sometimes just can't give information beyond the presence or absence of effusion and whether it's causing hemodynamic disturbance. I'm sure the contrast echo studies can help us in this situation, but we don't have any experience. So that's it. And I just leave the floor open for discussion because we could have, and I'd like Dr. Chandrasekhar's opinions about some of these cases.
Thank you, Dr. Christopher. Those were very nice cases showing the power of imaging. Let's open it up for the audience and then I'll come back in the end with some comments. Any takers? Go ahead, Dr. Mohan.
Current view, would you look at the anatomical severity of the disease or functional severity also to decide for revascularization? Now that question has been repeatedly coming to our mind, because should we spend money on these things or not? Just look at the severity, multiple critical stenosis, triple vessel disease, with or without LV dysfunction, go for revascularization. Why do these tests at all, even if the patient has LV dysfunction relatively asymptomatic?
Right. So you touch upon some very controversial areas which 20, 30 years of research we have not been able to establish, right? So let's start from the very basics and then go into deeper analysis. So essentially when we are diagnosing coronary artery disease, we still don't know what is it that we are treating. This sounds surprising. I am the co-chair of the SCCT guidelines on cardiac CT that will come in 2019. And we are trying to give it a different flavor here. So one of the things we have to establish is, are we treating a flow limiting stenosis? Are we treating a flow limiting stenosis that causes ischemia? Or are we treating somebody to prevent future death or MI? Depending on the questions that we have in our mind, that will help us decide what we are trying to do. You would be surprised, I mean, especially the trainees and the fellows would be surprised. We know ischemia is bad, right? That's why Dr. Christopher did a SPECT and showed ischemia and operated. There isn't a single good trial showing that treating ischemia is good. We know ischemia is bad, but we don't have good evidence treating ischemia is good, correct? And so that brings the question, we are spending so much time doing all these studies. If we find out ischemia is a marker for something else, then we are probably chasing the wrong. And that's what the ischemia trial will show, right? They are looking at moderate ischemia, whether you bypass or revascularize or not. And my guess is that trial will be negative. And so we'll be stuck with the same thing, that is, are we treating ischemia? Are we treating stenosis? Now this we've had since the CAS studies and all, 3-vessel disease, LV dysfunction, stenosis, you graft them. But the difference is, if you do 3-vessel angioplasty and revascularize them, you don't reduce death or MI. In fact, you increase death or MI, correct? So essentially, when we are bypassing somebody, we are not treating the stenosis. What we are doing is we are buying insurance, that in future, if any plaque ruptures anywhere around that whole length of the artery, you have an alternate blood supply. So at this stage, we are really not sure what we are treating in coronary artery disease. And that's why this debate whether we should treat stenosis or treat ischemia, and ischemia trial was supposed to answer that, but unfortunately, they have diluted and dumbed down the entry criteria so much now to finish the enrollment that will be a negative study. And so my personal feeling is, if you are going down the angioplasty route, you are just treating symptoms, right? So angioplasty is like a glorified medical therapy for most patients. If you are talking about the subset where there is mortality benefit, 3-vessel disease, LV dysfunction, remember those trials were done without any of these tests. So you might as well bypass them and treat them. So that is where the whole confusion is. And so in my practice, I get physiologic information, either FFR. FFR is easy for us to do, IFR is easy for us to do because that's the way our health system is structured in the US. But I realize, as Dr. Christopher pointed out, there are cost constraints. But you need some physiologic information in addition to anatomy to treat. And so the physiologic information can be stress testing, can be vitamin stress echo, exercise echo, or FFR. So that's the way I would look at it.
Two or three vessel borderline lesions. Ischemia is positive. You showed by doing this, the ischemia is there, lesions are just 40–50%, all three arteries. What am I going to do? That is my confusion. And that is not, that is a substantial number of patients. Nearly 1/3 of my practice involves those people who have lesions which I am not convinced, but the stress test is positive. So what am I going to do? Put a stent, put them on drugs, go for surgery, and I don't know what is the source for that ischemia. Is it those epicardial vessels or lower down somewhere? And I don't know whether I will be benefiting them. And so we have done some angioplasties and we have realized that these guys remain symptomatic despite that. And that is when you get a whole disrepute. The technique comes in disrepute, physician comes in disrepute.
Right. So it comes back to the same issue that we all think we know how to treat coronary artery disease, but if you read the literature very minutely, a lot of things are unknown, and that's why we kind of go by cabbage trials which were done 30 years ago when none of the current medical therapy existed, correct? We are still depending on left main, 3-vessel disease, LV dysfunction. Salim Yusuf had a very interesting paper about 20 years ago on this. So you would be surprised that if you graft a 3-vessel disease with LV dysfunction and say there is benefit of doing cabbage, on an average those guys get 8 months of extra life. So it's not like you're changing their life, and those 8 months are not very productive 8 months also. So a lot of stuff we do with just blind faith and not real objective evidence. And that was one of the questions I was going to ask Dr. Christopher. Like in some of the patients, for example, the CTO patient, we do this CT and show the distal anatomy, we show myocardial CT perfusion in some sense, we show an equivalent of delayed enhancement. Now we are extrapolating, saying that this information made us more wiser to do the CTO. But this doing a CTO or not in the first place is being questioned, right? So all this extra information, we feel that we did something useful, but the basic technique itself is suspect. So it's a very, if you don't read too much, you are a great doctor because then you don't have to think, right? But if you start reading too much and thinking, cardiology is tough, right?
The only thing that I would like to add, and Dr. Chandrasekhar has put it very well, is that I think by the use of some of these tools, I think we are learning more, and that's important. We are learning more into the insight of some of these patients, right. Insight into disease, microvascular disease, for example. We have had patients with significantly positive stress MIBs. Take them to the cath lab, no disease. And then the cardiologist said that your technique is bad. But we didn't know that there is microvascular disease in this patient, elderly diabetic lady, for example. and that if you fix that using drugs and good sugar control and the optimal medical management, the angina goes away. Epicardial coronaries are normal. So I think these imaging tools, to me at least as a cardiologist, has given me some kind of an insight. We are not yet there, but we are at least proceeding in the right direction. I think that's very important, that we are able to look at some of these, use these appropriately, as I said, in a very cost-effective manner. The cases that I've showed are obviously many of them off-label, but I just wanted to give you a flavor of how you can interpose imaging in your practice and at least go somewhere, if not in the right direction. So just once again, thank you for the opportunity. Thank you, Dr. Chandrasekhar.
We come to the close of the session, Potpourri of Cardiac Imaging Beyond the Echo. We thank Dr. Johann Christopher for his presentation, and we thank Dr. Y. Chandrasekhar for his expert comments.